craniocervical pathology. Dr. Bowman is an expert in this field, and I love seeing his newest tricks that he does for these minimally invasive ways. So, Dr. Bowman, go ahead.
All right. Uh, Mohammed, thank you for the kind introduction. I think compared to some of the more preeminent people on this talk, my talk is going to be more of a work in progress. It's things that I'm working on recently, trying to move the field forward when it comes to craniocervical junction pathology treatment. I'm Deb Bomick. I'm one of the neurosurgeons at Duke University in North Carolina, United States. So let's see here. These are my disclosures. And then, I think I'm going to start this off by just talking about one of my passions and just really in, research focuses is the use of, minimally invasive treatments for cervical disease. It's a fairly new field, and the reason, the rationale for it is the idea behind use of minimally invasive techniques for cervical pathology. While it's been around for a while, the use of instrumentation and advanced decompressive techniques are just starting to be realized with the use of endoscopy and minimally invasive instrumentation. But the main reason for doing this is to help patients, and the hypothesis is that we can avoid a lot of the negative side effects of posterior muscle detachment that occurs from posterior approaches to the spine, such as infections, muscle atrophy, pain, kyphosis, and adjacent segment disease, as well as all the various issues with open surgeries that we deal with. And I'm sure that that's going to come up later with some of our other speakers too. So what is minimally invasive posterior cervical? It's what you think it is. It's the use of surgical spinal procedures, including decompression and arthrodesis or fixation, not requiring a midline fascial opening. So, the idea behind this is to minimize muscle stripping from posterior elements. There were a number of us that got together to move this field forward, and we decided that the levels involved with the surgery would be from C1 to 2. I'm going to potentially challenge that today. And then, the idea is to be able to do this, we would have to use adjunctive tools such as imaging, navigation, various forms of advanced retraction and minimally invasive visualization. Now, while I'm saying that it's a new field, it's actually not a new field. There's a number of different attempts at minimally invasive cervical spine surgery that have been extremely successful. Starting out with tubular or endoscopic posterior cervical foraminotomies, which are now commonplace. These new facet grafts that people use, or facet screws for posterior fixation, selective muscle sparing laminotomies, and then anterior foraminotomies have been done for years. I think the idea here is to use it for more advanced procedures now. So what's the current state of the art for minimally invasive posterior cervical instrumentation and arthrodesis? It's, the use of navigation, as you see here, the use of paramedian incisions, potentially, minimally invasive pedicle screws, specialized instrumentation with extended tabs, and then what's not shown here is various types of decompressive procedures that are done through non-midline incisions. And these are some of the publications that have come out from this. I think, the challenges that we have to do with imaging. It's not as simple as some of the lumbar minimally invasive surgery fluoroscopic landmarks. So most of us have gone to use of 3D image guidance. There's a lot of soft tissue interference. It's very difficult to put down a tubular retractor without pushing on the spine. And there are some specialized techniques that have to be adapted for minimally invasive posterior cervical surgery. And then, of course, how do we graft and create a fusion bed and do adequate decompression. So those are very general terms being used for posterior cervical. I'm going to cone it right down to craniocervical junction right now. Probably just focus mainly on just instrumentation and arthrodesis for this initial example. This is an example I use a lot because it was probably one of the easier craniocervical junction surgeries we do, which is a posterior C1-2 fusion. This is a patient that had a minimally displaced type 2 odontoid fracture that displaced further upon upright imaging in a cervical collar. Given her young age and her comorbid obesity, it was very unlikely that she would be able to go ahead and heal this in just in a collar. And so we elected to consider her for a C1-2 posterior fusion. An odontoid screw in her was discussed, but could not be performed just given her body habitus. So this was a procedure that we had developed to perform a minimally invasive C1-2 fusion. It's a modification of the Goldharm's atlantoaxial fusion. On this model, you can see we use a specialized shim that goes into the intra-articular space between C1 and 2 that gives us access to that space in a minimally invasive manner, and then are able to place a cage into that intra-articular space. And then afterwards, use of biplane C-arm and navigation and/or navigation, we can place posterior cervical screws with extended tab extensions to allow for percutaneous rod fixation. So here's how we did it. It took us a lot of trial and error to figure this out, but we found out that we needed to actually cannulate the C2 pars or pedicle, depending on the patient's anatomy first. And that was oftentimes the first step. The second step was the placement of the intra-articular graft. We did this bilaterally on this patient, so you could already see that her fracture very quickly reduces as soon as we place the intra-articular graft. And then, and this is a departure from the Goldharm's technique, is that instead of going over the top of the C2 nerve root, we actually follow the C2 pars and go under the nerve root to access the base of the C1 lateral mass. And that's facilitated by the placement of these cages. The cages actually raise the level of the base of the C1 lateral mass, and that allows us to cannulate the C1 lateral mass. And then we go ahead and place the extended tab screws, and then percutaneous placement of the rods. We published our small series of this technique, and this is one of the figures from that. And I won't beleaguer the point, but it significantly decreased the amount of blood loss and overall exposure time of the spine. What what I'm really excited to talk to you about today, though, is you know. The newer things that I'm doing now, leveraging some newer technologies to allow us to treat both basilar invagination and retroodontoid masses through minimally invasive approaches from the posterior cervical spine. Um, and this is the part that where the work is still in progress. You know, Currently, the options for approaches are, OC fusion with or without, traction, plus or minus transoral or transnasal odontoidectomy. And then certainly there are, intra-articular impaction procedures that I'm sure that we'll be talking about later in this conference that sometimes obviate the need for even an odontoidectomy. What I wanted to do was be able to tackle some of these basilar invagination or retroodontoid masses through an all posterior approach, so that transoral or transnasal approaches would not be necessary. And I do have to say that there's a lot of simple cases that can be done with transarticular impaction, cages, but when you're dealing with pretty significant malformations of the odontoid or masses in the retroodontoid space, it can be very difficult to disimpact with just an intra-articular cage. So I wanted to develop a newer way of doing an odontoidectomy. So I came up with this modified far lateral approach with a partial resection of the C1 lateral mass combined with the disimpaction. The first example I'd like to give is of a patient that I saw in clinic with a retroodontoid mass. It's pretty severe looking mass. It initially looked to me to be a possible synovial cyst of the atlantoaxial joint. The patient had new onset of non-ambulatory status, severe spasticity. He'd been dealing with upper and lower extremity weakness for at least 2 years, but it had progressed to the point where he showed up in my clinic in a wheelchair. He had a new dysphagia, so some lower cranial nerve pathology as well. And as you can see here on the MRI, it's a little bit hazy, but there's this retroodontoid mass. You can see it also on the CT scan. Pretty well preserved bony anatomy of the odontoid. So really, the only abnormality is this mass that's pressing on the lower brainstem and upper cervical cord. And so I think, in previous times, I probably would have approached this through a transnasal endoscopic odontoidectomy and then aspiration of the mass or removal of the mass. I think this could easily be approached through a posterior approach, but with some significant caution, especially given the amount of compression. So myself and one of my skull-based partners decided that we would come up with something a little less invasive than a normal far lateral craniotomy for this. And this would be a mini open type of far lateral approach where we performed a modified hockey stick incision here on the posterior cervical spine and in the cranium. Um, Formed a small foramen magnum craniectomy and mobilized the vertebral artery above the lamina of C1. By mobilizing it superiorly, we can remove that lamina, remove part of this dorsal lateral mass, and with combination with removal of or ligation of the C2 nerve root, can reach laterally into this space in the retroodontoid space through an intradural exposure. So here's a short video of that. You could see there is the mass underneath some of these rootlets of both the descending spinal accessory nerve as well as the C2 nerve root, and then a small opening in the ventral dura and into the mass, and you can see the cyst material coming out there with some significant dissection. We were able to evacuate the majority of the cyst material. We were very fortunate in that it wasn't very firm. I'm going to just move a little bit faster here, and there's us removing some of the ventral ligaments as well and dissecting around there. And then finally, a ventral dural closure. We can fast forward to that. In the end, the ventral closure was not necessarily extremely successful. We actually ended up needing to place a lumbar subarachnoid drain, and then the patient was able to be mobilized very quickly thereafter. The patient improved to ambulatory status and 5 out of 5 motor exam by the 6-week visit. Here's the immediate post-op imaging. It was not extremely impressive. You could see a little bit smaller cyst cavity here, but then by the 6-month visit, it had completely resolved and without any residual brainstem compression. The diagnosis was a little bit of a surprise. It was amyloidosis, which was confirmed by a fat biopsy. So what you saw there was, a mini open type of exposure. So, I didn't use my minimally invasive techniques for instrumentation. I didn't use a small incision to expose the mass, but it did allow us to make a small window into the retroodontoid space. And it got me thinking, now that I know I can do a small exposure, can I do it even smaller so that I could use smaller tools? And so the idea came to me to use an endoscope now for this, far lateral. And that would allow me to place a drill and potentially perform an odontoidectomy. The idea behind using an endoscope is mainly it would allow for protection of those cranial nerves in the brainstem. It would allow for visualization of what I was doing, but I would still need partial reduction of the odontoid into the foramen magnum, especially for a large incursion of the odontoid process. And I still would need some type of real-time imaging or navigation to allow for me to know where I was in space. And then the other thing I wanted to try, mainly because I didn't want to have to necessarily deal with a ventral dural closures, possibly trying an extradural approach. So my next step was to try this on a little bit
Dr. Bomek,
simpler.
we're gonna have to ask
Yeah,
you to because
yeah.
we got three
Okay,
more speakers.
I'm gonna move very quickly then. I'll go through this example of another version of basilar invagination, mainly from an atlantoaxial instability. Um, and so I'll just show you the steps of this. This one I still did open, but I just wanted to test out the use of the endoscope for this approach. We did the indirect disimpaction. There was still odontoid in the foramen magnum, did the drilling of the lateral C1 lateral mass, and then finally the drilling of the odontoid process from the posterior approach. And then this was the postoperative approach. So future uh, plans are to combine all of these techniques into one singular procedure that can be done completely minimally invasive, but we're still not there yet. So that's the next step.
Amazing
With
work
that,
as
I'll take any
always.
questions.
Impressive work indeed. Yeah, it is great that you presented that to us, and we will hopefully have you in the future to present what else you have done and how you are advancing that. And Muhammad, thank you so much for inviting your partner to that forum. I suggest we put we leave the questions at the end, unless there is anything that's burning now. But I suggest we put all the discussion at the end. Is that okay?
Yes.
Okay. So well, that's great then. So it will be we will go as announced in the brochure. So it will be my great pleasure now to present next speaker, who is Professor Sushil Patkar, who is from Pune, India. He's a consultant neurosurgeon in Pune Hospital Research Center. He is founder and past president of Neurospinal Surgeons Associations of India. He's founder and past vice president of Neurological Surgeons Society of India, and many other. He's going to talk to us about innovations in craniocervical fixations. Sushil, are you on? Are you ready to continue?
Thank you. Yes, good evening to all of you from India.
Hi, good evening
to all of you. So I'm just
can
getting
share.
my.
Yeah, I can share your screen, please, with us.
I'm doing that. Yes. So I think yes.
We can see. Just start your presentation. Start. Press the button. Start.
Yeah, just a second. You are screen sharing. I am all right on it. Okay. Can you see my?
Yes,
can
we
you
can
see my
see
slide?
Yes, we can see it, but just start it from the right bottom corner. You know, this button that you can start your presentation.
I cannot see any button which says start.
Yeah, just go right now. Go down, all the way down, and then you're gonna see a couple of buttons there. Just go all the way down and go right. And you see this minus just next to the minus. Before the minus, there is that
this
button.
one. This one.
Yeah, that's it. Okay.
Okay, have I started? Am I there?
Perfect. Yes. Just carry on now.
Okay. Good evening to all of you from India, and I'm very happy to see there are so many people online listening to this webinar. And most important is my friend, Dr. Atul Goel, who has been always my stimulus. I hope, Atul, you are there. So I'm going to talk about some innovations which I have contributed to make life simple. This is where I've been working. Most of my work was done here in Pune in these hospitals. And I work presently at the Pune hospital. I feel that experience comes from complications if you avoid litigation. And most of the time when you begin, I had begun over here, I went on to think I knew everything. And then slowly you start realizing where you have reached. And then gradually I tell you I have reached over here and I still feel there's a lot more to learn. And as your knowledge increases, you realize that how much more is there to learn. I have no disclosures whatsoever except my mentor, Professor Ramani, and my wife, who has been my anesthetist all over the time. So if you see, when I began in neurosurgery, all craniovertebral surgery was like this. William Galley and Alexander, etc., we all know them. It was always like riding the horse and trying to control it by catching its tail. The predominant movement, when you talk about craniovertebral surgery, the predominant movement is at the atlantoaxial joint, and any way that stops the movement controls the joint. So Nagel was the first person in 1986 to describe this technique of transarticular screw, all of you know. And you see the recent paper where by Fessler in 2020, it still says that the stiffest stabilization with the least amount of rotation is nothing else but posterior C1, C2 fixation by a transarticular screw. It should be considered the gold standard. But then the entire surgery revolves around, the discussion goes around the vertebral artery, the bleeding from the paravertebral venous plexus, and the difficulty encountered in trying to put the screws. The vertebral artery, of course, can be high riding, and that can be a problem. And it is, my friend, see this, sometimes the vertebral artery can come out dorsally. It was my friend Atul in 1994 and who described this technique of lateral mass screws and power screws. And it took a long time. I was very happy to see the slide of the previous speaker where he has called it Goel-Harms technique, because for long it was called as Harms technique, but things have changed. But what are the problems? The axis slips over the axis, there's venous plexus, there's vertebral artery, the C2 root ganglion, and plus there are so many muscles. The minimal invasive concept also came because all the muscles behind are extensors which hold the C1, C2 in position. You actually damage them fixed from behind. Necessity is the mother of invention. Research means search again. It is already there. So way back in 2013, when we studied the scan, see that there's a fallacy in the course of the vertebral artery is variable. But if you study that the scans are done in axial plane, you have to do a 3D CT scan, and you'll always find that there is dense bone under the facet. And if the screw is passed just under the inferior edge of the facet, you can remain anterior to the vertebral artery. And this was the technique called a subfacetal technique, which I have described way back in 2016. Subsequently, many other people described modifications of my technique. If you see the coronal scans, you'll find you should study the scans always in coronal plane, and there is always dense bone, howsoever the vertebral artery may be right. So one can pass a screw very easily under the facet, and the densest bone, the maximum stress is under the facet because the weight gets transmitted from the lateral mass onto the facet, and therefore you get a secure hold over there. So this was a technique described by me in 2016, new entry point, significant. This word significantly I had to put because the one of the very eminent surgeons from the US who was the peer reviewer, he was not ready to accept that there will never be a vertebral artery injury. But believe you me, when you remain under the facet, there's actually no way in which you can really injure the vertebral artery. And then this was published at various places. Then I went on to modify and made a VSP plate construct for this. This was the VSP plate construct, and in which, if you'll see, one could manipulate the joints and then use the plates, and it's like the lumbar spine, where you can use a plate screw construct and a top loading nut. This was presented to the American Association of Neurosurgeons. And if you see that once you have the pedicle screw construct, you can reduce the joint if you open into the joint. There is no capsule to the joint. You have to get the screw correctly in position, and you can reduce the joint. So this was the entry point which I described. This is the joint. This is the lateral mass. This is the C2. After opening the joint, you can, and I put the screw just under the facet in the midline. This was the new entry point which I have described. And then once you make use of that, you can pass. These are modified screws made for me by a company called Geon, with whom I have no financial interest. And once you do this, you can manipulate the joint into reduction. You can put a cage, whatever you want, and the same way like a posterior fixation. But the polyaxial screw does not permit you to do that, which you can easily do with this kind of Steffi screw. So this went on to get published in this Journal Neurosurgery focus video where I was one of the editors, and this illustration of mine is there on the cover page also. And those who are interested, they can read this article where it improves the biomechanics of fixation. Now, many other people went on to describe this technique and passing the screw just under the facet down. And recently in 2022, there was a paper from China in Journal of Orthopedic Surgery and Research, where they described that this technique was one of very beautiful technique. Whenever the vertebral artery is in your way, there is no need to manipulate the vertebral artery, and you can always remain ahead of the vertebral artery. Then subsequently, in the journal by Dr. Goel, one of the doctors from India, professor, has published the advantages of this technique. But now you will see most cervical spinal surgery, like subaxial spine, was described by orthopedic surgeons, and it moved from posterior to anterior. Both Galley, Magel, all these were orthopedic surgeons, and it was the pre-microscope area. And I don't know why cervical spine moved anteriorly, but stopped short at C3-4, or sometimes at C2-3. Tradition versus new thinking. The one who follows the crowd will not get further than the crowd. If you study, the weight is transmitted from the lateral mass to the facet. So the fixation also has to be along this line, flush with the bone, not somewhere behind like an external fixator. So if bulk of the weight is being transmitted here, your plate or your screw must be flush with the bone to get the best secure. So when you go back to biomechanics, you will realize that the most dense bone is under the facet of C2. And to avoid this, as long as the head can be extended and the angle of the mandible is going above the mid C3 body, this site is easily approachable. I don't know what was the reluctance of neurosurgeons to stop over here with the microscope. It just required tilting the microscope and taking the incision a little bit higher. And this is how the head is fixed. I have always these Gardner-Well tongs. And 95% of the times you can approach the C1, C2 joint easily from the front without any problems. So this was the classic Indian god who probably underwent some kind of transplant. So I will just show you a small weight of how it is exposed. So the head is externally rotated to the opposite side with the Crutchfield Gardner-Well tong. The incision is 1.5 inches below the angle of the mandible. There is no important structure. Your approach is between the carotid artery without disrupting any muscle. The only structure is the hypoglossal nerve. As long as you remain below the digastric tendon, you are not going to damage the hypoglossal nerve, and you are directly onto the C1, C2 joints. So this minimally invasive concept is that you don't disrupt muscle. The biggest muscle that you cut is the platysma. After you cut the platysma, you will see the digastric muscle. And once you see the digastric muscle, you mobilize the digastric muscle, and this is the stylohyoid, which splits and goes around it. You divide this as submandibular gland. This is the digastric tendon. You mobilize the digastric tendon upwards, and you will be on to the C1, C2 joints. The patient is in supine position with the head extended. This is the hypoglossal nerve. Remain below the hypoglossal nerve. And with finger dissection, you are on to the prevertebral space behind the oropharynx, behind the nasopharynx. Provided the X-ray had shown that your mandible had gone above, and these are the right angle retractors, the long ones, Langenbach's, and which will take you straight onto the C1, C2 joints at the anterior surface of C2. Of course, you can confirm by doing a C-arm. This is the midline, the longus colli muscles with the two joints on either side. The secret of a good atlantoaxial fixation is your capacity to garden the joints, graft the joints, and then fix the joints. So when you are in the front, there's no vertebral artery, there's no venous plexus, there's no C2 root, there's a large block of bone available to you, and you can pass with a microdrill. You do not require navigation, you do not require any 3D modeling. This is anterior cervical fusion, which can be done by a registrar. It is not a very complex operation. You can see how the screws go. And like I said, biomechanically, the anterior transarticular screw is the most superior kind of fixation. Now, another point that is important is after you've exposed the joints, you can manipulate by removing the soft tissue between the anterior arch of the atlas and the odontoid, you create instability to reduce deformity. So this is going under the atlas, removing the soft tissue joint and creating instability. Only then you can reduce the deformity. This is the basic principle of spinal surgery. So after I've exposed the joints, created the instability, the next step will be to impale the odontoid and pull the odontoid process towards the anterior arch of the atlas. This is I'm making a drill just under the base of the odontoid process and I passed a tap to pull the odontoid towards the anterior arch of the atlas. So this tap is in the odontoid process and you reduce it and then pass the transarticular screw across the joint. And under vision, so you are seeing that you are going under vision. Again, I'm re-emphasizing that there is no discussion, no talk about where is the vertebral artery. And this is the tap. I don't like to tap too much, just a few millimeters into the lateral mass of atlas, just to get the correct direction. And then you pass the screw, or you can put a plate across. So I'll just skip this to show you how I pass the, this is on the opposite side. I'm passing the transarticular screw. So this is one way of doing it. The other way is to make use of a plate and put a plate across, one screw into the lateral mass and one screw into the body of C2. So now just see the difference. The only muscle that you cut is the platysma and then a few fibers of the longus colli, vis-a-vis the posterior surgery, which is a biomechanically destabilizing operation. And when you put implants over here, the muscles are never able to fall back and they are never going to heal. It is going to be a big scar behind, and the patient neck movement should always be restricted with a lot of pain. So biomechanically, the force nucleus in the front, the line of weight transmission is across the lateral mass. The quality of bone is more solid when you do it from the front, and the technique is safe and simple. So these are some examples, and you see in literature, there has been a resurgence in the recent times towards doing anterior transarticular screw. In fact, you see 2020 that this is anterior transarticular screw fixation is going to come back. Over a period of time, many people have published their work, and recently, a few years ago, there was an editorial on my technique from the Indian Journal of Spine Surgery, and those who are interested, they can go back and read that. Not many instruments are required. You can see the drill, just a micro drill, some right angle retractors, and hardly any instruments. Very simple, very, very simple screws. No complex, instrumentation. Nowadays, these instrument companies, they come with such big boxes, and there is one screw instrument to open the box and one to close the box also. And it's not required. So you can see some examples. You can see how the screw is going across with bone grafts in the joint. And another example, you can also put plate, and you can see how this, you can see I have to put bone grafts initially, and over a period of time, how it is fused. And another example, the end point has to be fusion of the joint. If you're not getting fusion of the joint, all this, gamut about fixation is useless. At the end of 6 months, maximum 9 months, the joint should have fused, whatever technique you use. And see, this is through a very small incision in the submandibular region with a dissection between the muscle planes, and all the neck movements are free. Unlike the posterior surgery where there's a big scar, all the muscles are disrupted, and you can do this 95% of the times. So these are some other examples. You can see in odontoid, there are various types of screws which are used. This has to be the end point at 6 months, 9 months. And if you cannot get in this with whatever technique you are using, then thank you very much. So this work also got published. And the first time, 2013, I published in Japanese Spinal Surgery, where I described that the unilateral approach, you can put anterior screw plate fixation extrapharyngally. Transorally was described way back by Dr. Goel, and he stopped doing it because of the infection. Then the next thing that caught my attention was basilar invagination. There was no consensus of treatment. And my friend Atul described the technique of distraction to reduce the odontoid process and putting cages. And then, of course, there were other people who published. And then my friend Sarat Chandra came out with a new concept of facetal realignment and his technique of DCR. I don't know how many of you have seen the operation. It looks very interesting, but very, very complex with a lot of instrumentation. But yes, he proposes that operation DCR. I feel that in those patients where the odontoid has gone inside, this kind of case is not a case for any kind of distraction. This kind of patient is going to require a transoral odontoid excision. I do not believe in this concept that all odontoids are reducible. Then I came out with this technique of anterior release. What is holding the patient in atlantoaxial dislocation are the anterior ligaments and the abnormal muscles. Cutting the muscles, you can put a cage inside and you got a lot of bone for fixation anteriorly. And the concept is that if you put a wedge inside, it is going to push the atlas upwards and backwards. So this was the concept, putting a cage. And you can see some examples. See, these were the specialized cages made for me again by Jeon. And you can see the long-term result with the fusion across the joint. And it has got fixed in the reduced position. And another example, this is a new concept, the grab oaks line from the clivus to the C2. What is important is the amount of cervicomedullary strain. It is not important to reduce, as long as this is less than 4 mm, that is sufficient. It is called a grab oaks realignment. So you see this preoperatively and see this postoperatively. With the cage, you can realign by creating, you can pull the odontoid in the front and fix it and get the cage inside. And this is the concept. You can see some more examples. You can see this odontoid which has gone inside, brought back down and fixed in this position with the cage in the joint. And long-term showing the fusion. And this is what you can do. This is possible. I published this way back in 2016. Anterior facetal realignment and distraction for atlantoaxial subluxation with basilar invagination, first as a technical note, and subsequently neurospine, demystifying surgery for basilar invagination, the wedge technique. And then again in neurosurgery, yellow neurosurgery, those who are interested, this article is available free on the internet. They can see the steps and how it is to be done. So I will not spend time showing the video. Then I went on to make this kind of, like the low profile in the cervical spine, we made this spacer to be put in the C1, C2 joints, where you can lock the C2 screw and the C1 screw and pass the spacer in the joint. Just let me see if this, the concept was like this, that if you can if you are able to push something to the joint, you can get the odontoid down. And if it is wedge shaped, then you can push the atlas upwards and backwards. And there is a lot of bone over here and down. Fix. Of course, we don't cut the anterior arch of the atlas. We just push the cage into the joint. And once the cage is in the joint, we have the screw going in the lateral mass and into C2. And I tried to take bicortical screws. I measured the length on the CT scan. Of course, this has got published. And then, sir, my friend Sarat Chandra has invited me a couple of times to the All India Institute to demonstrate. And now they have started doing this technique at the All India Institute of Medical Sciences in New Delhi. So this was another problem when the case of basilar invagination with the dorsal art coming out dorsally. And then I went back to the drawing board and I found there's a lot of lateral mass here where you could pass one screw into one lateral mass and one in the center, and this could be easily reduced. So you can see this case of basilar invagination. You avoid the posterior surgery and this can be reduced, and you can put a lot of bone into the joint and realign the joints. And of course, this got published again as basilar invagination surgical treatment by a novel anterior implant. This is another concept, the patients where, you cannot do lateral mass fixation. See this kind of patient, if somebody had done an incomplete odontoid excision with those infection and osteomyelitis involving the C1, C2, and going right down. So this was fixed by a technique by me where I transmitted the weight onto the ventral cervical spine. And this was the long-term result and flexion extension. This was a case of fibrous dysplasia, where there was almost nothing available for fixation, and there was disease involving the spinous process, but these vertebral bodies were available for fixation. So this is how the weight is transmitted onto the ventral surface. And you can see this over a period of time with endocrine treatment, DMOSAB, and etc., various kind of bone reformation medication. Over a period of time, you can see that the bone has reformed. And I feel that this kind of operation going below from behind, disrupting all the joints, and very little to hold, bone to hold as compared to the vertebral bodies, will over a period of time disappear. This got published as a new technique of craniovertebral fixation in neurological research. And the technique is very simple. There's nothing complex in it. So this is how it is done. You expose the cervical spine and just see that lateral to the trans, if you do the C-arm, AP, if you go laterally, there is nothing, there is no structure over here except muscles. So there is a safe area. So these rods, these are customized rods made for me, and they are bent at 2 angles and pushed under the lateral to the C2, far away from the vertebral arteries. And then they are fixed to the vertebral bodies by this modified kind of connector, and the screws are passed to hold them, and they are off the midline, so they don't jut onto the esophagus. And these are usually bicortical, and then the rods come out behind. I take 2 vertical incisions. I don't separate the muscles in the midline. Vertical incisions on the sides, and then this kind of plate fixes the rod over there. The rod is bent, and this tip is exposed. So you can bring the rod, and with the domino connector, you can connect it to the rod with a separate incision over the rod. This is how it is put, and the head is held in extension, and you can fix it. Sometimes if it is mobile, you can reduce it and fix it. This is how the final construct looks. So this was the patient who had a pathological fracture of the odontoid, and you can see how the cord was deformed, and this was the construct. And over a period of time, now this is more than 5 years follow-up. And she says that after 2 weeks of surgery, she recovered completely, etc., etc. So the truth is more important than the facts. The facts are what you see. The truth is what exists, my dear friend. Odontoid fractures, is another kind of complex acquired CVJ, because most of the time odontoid fractures, this classification is too simple because it is not just the bony injury, but also the ligamentous injury and associated bony injuries, which can completely change the approach towards odontoid fractures. The screw has got too many required. To get to do a perfect screw, you have to be perpendicular, it has to be bicortical, and most people don't do that. And then the screw can walk out from the anterior cortex, and you can see, that the screw can fail. And this kind of fractures will end up in transoral odontoid excision and posterior C1, C2 fixation, because you cannot relieve the cord compression by any technique. This kind of patient where there is no facetal injury, there is no associated hangman's fracture, there is no description of how to approach them with this Alonso's classification. So the classification is incomplete. Displaced impacted fractures, comminuted fractures, osteoporotic fractures, and associated fractures are not addressed by the present classification. So the Rosetta Stone, manipulation of the facets, is the secret to correct craniovertebral anomaly. So this was the technique described by me. By going ventrally, you can push osteotome, tilt osteotome, push the odontoid upward. What is holding the person in deformity are the anterior contracted muscles. What causes flexion at the C1, C2 are the muscles and the ligaments, cutting the longus colli, cutting the rectus capitis anterior and the anterior longitudinal ligament. You can reduce any deformed odontoid fracture. This was again published, Anterior Facetal Distraction, a technical note. So you can see that, I'm sorry, this slide has got repeated. So the secret is for instability is, you cut these muscles. Once you have cut the longus colli, then you can reduce the deformed atlantoaxial joint. And then I went on to make this kind of plate, which is a VSP plate, which you put across the fracture and pass bilateral transarticular screws. And you can manipulate the odontoid and get into position by holding by the odontoid process. So direct compression, reduction, fixation of odontoid fracture. This was published way back in 2017. And I'll just show you that this can be done like once you are in the midline, you can expose the anterior surface and you can see this after you have identified the fracture, you remove the soft tissue between the anterior arch of the atlas and make the situation more unstable. And you can almost reduce it by pushing the fracture into alignment by using the right angle retractor. Or you can impale it with a tap and hold it in the position that you want, then put a plate across the fracture, and then pass the bilateral transarticular screws. So this was holding the plate with a VSP plate, and then I'm passing the transarticular screws across the joint. And you can see this, that on table, you can check, which you cannot do in prone position. Plus the prone position is in a compromised position when there is an atlantoaxial dislocation. So this was the construct described by me, where you can treat the fracture and treat the instability by the same approach. Reduce any fracture, bring it into position, and you can, what has happened? The concept is, the VSP concept is that once you expose the fracture, once you pass the second screw is passed close to the edge of the hole, and as it slides, it will push the fracture into position, which will enhance the fracture healing. So you can see this example when there is a fracture. Suppose the fracture is anteriorly inclined, you cannot treat it by the ventral screw, but you can plate it by this technique of VSP plating. Now, displaced fracture, you can impale the fracture, cut the muscles, bring it back into position, and once you have brought it back into position, you can put the plate. And then you can do the bilateral anterior transarticular screws to treat the instability also. So these are examples. This is an old fracture which has impacted in a bad position. And this is how it is reduced. You bring it into position, and over a period of time, you see that the fracture site has healed. So this is sometimes to pass the transarticular screw is not easy. So when we studied 350 scans, we found that you could pass a screw very easily from the anterior inferior end of the atlas. And this was the plate which was made again for me, where you have locking screws, and 2 screws can be passed in the center, one across the fracture over here above and one in the center. But these screws, of course, have to be bicortical, like I said. And these are examples of, a displaced fracture, impacted fracture, reduced, repositioned, and over a period of time, the fracture has healed, and the lateral masses and the weight is transmitted. A 3-point construct is superior to 2 separate constructs. There is no parallax movement, and this got published again in Case Lesions in Journal of Neurosurgery. For those who want, they can go and see this unstable odontoid fractures, a technical appraisal of the anterior approach, and the videos are also there for those who are interested. There has been a lot of literature from China about the surgical treatment for basal invagination using the TARP plate. But of course, this is a transoral plate and not extrapharyngeal like what I do or what I've been doing. And they claim very good results with the TARP plate, and they also have got devices to reduce the basilar invagination. And in 2023, they studied the biomechanical properties of various kinds of fixation, including the Goel-Harms technique, and they found that the anterior plate, which holds both the atlas to the body, is more superior than the other techniques. So I think that eventually the fixation will shift anteriorly. The TARP plate from the front or my plate, I think that is the way to do the atlantoaxial fixation. I've been going around the world talking about this. This was in Aberdeen last year, and this was just a few months ago in Indonesia. And then various countries around India, they have been started this technique by me. And this is my friend, and he was a guy who kind of stimulates me all the time. This is over the years, from hairier days to losing our hair. We have been continuing to have our boxing matches. But of course, I love him, and he's one of I think the most brilliant surgeons that I've encountered in my life. Last year, this technique was given some prize by the Society of British Neurosurgeons in Edinburgh. So I feel the task is not so much to see what no one has seen yet, but to think what no one has thought yet about what everybody else has seen. Thank you very much, my dear friends.
Thank you so much. It was really interesting presentation, and you have obviously very you have developed a lot, and thank you so much for sharing your great experience, and we can only learn. I might ask you to share some videos later on. Now, I think we have to move on, and we will present the next speaker. Muhammad, do you want to present, please?
Sure. Next speaker is Dr. Wa'il Shaya. He's a young professor at King Saud University in Riyadh, and also works at the National Guard there. And I've been very impressed with his work on craniocervical junction at various meetings. So it's an honor to have him present on the domino effect of craniocervical junction pathology. Dr. Wa'il, are you on?
Yes, yeah. Hi, everyone. So just I'll share my screen. Can you hear me?
Yes.
Yeah, okay, sorry, just a second.
Somebody so smart.
Uh, yeah, okay, can you see the screen?
Not yet.
Oh, okay. Share.
Yes, now put in presenter mode
Yeah.
and you should be good to go.
Yeah, hi everyone. Thank you for inviting me. So I'm going to talk about a new concept. It's a dominant effect of craniocervical junction reconstruction. So I do a lot of craniocervical junction fixation especially for pediatric. So I did so for over 150 cases. So I'm just elaborate about this new concept for the domino effect for fusion. So this is my disclosure. So like the craniocervical junction is the golden region for spinal balance by dominant effects. So if we think about it, for spinal balance, we have the pelvic incidence, which control the whole balance for the spine, which control, by lumbar lordosis and pelvic tilt, which affect the thoracic kyphosis. And I will explain that on the next slide, but all at the end result, it's the last compensatory mechanism, it's by the craniocervical junction. So introduction, the craniocervical junction, it's a region between the skull and the spine. It's very highly mobile. And in that region, it's very, very unique. There's no disc. It's basically all joint with different way of mobility, and it's all component of ligament. And it's very active region. It's a growth dynamic and geometry. It's active process. So if you, in the next slide, you will see how the joint change from age, from birth till age of 18. The geometry and the angle and the numbers all change. And also based of the time of intervention, that will be consequence over time. And as I said, there's no disc at that space, but it's all controlled by the ligament. That's why the ligaments have a major role for spine stability and the movement for the craniocervical junction. So when you talk about the cervical, when you talk about cervical sagittal alignment, we divide to two separate parts. We have the upper cervical, which is condyle C1, and the lower C3 down to C7, because what's the alignment on the upper cervical, it will affect, for example, a patient with the cervical, when you do more lordosis on the upper cervical, it will be reflected with kyphosis on the lower cervical as a compensatory mechanism. And I'll explain that a negative relationship between the upper cervical and lower cervical. So that's really important when you do fixation for the upper cervical. If you overcorrect doing more lordosis, they will be having consequences with lower cervical as compensatory mechanism with the kyphosis. I will elaborate that in more cases. So if you look to this slide, this is elaborate the C1 over time at the age of month, 1 year, 2 years till 18. You can see the lateral mass is small, and over time become more oblique and oriented obliquely, and it's become more closer over time. And the diameter, the AB diameter, will increase, and the lateral diameter decrease. That's resulting consequences about the movement of the craniocervical junction. Same thing applies for the odontoid. If you see the dents over time to start to grow, and the canal also changed in the geometry and the angle of occipital condyle, sorry, the C1 with the C2, it become more obliquely oriented compared to during the first 2 years. It's parallel to the C1, C2 joint. So that will be affected the mobility and range of motion of the craniocervical junction. So when you talk about the range of motion, so usually we say, flexion extension, it's between occipital condyle and C1. It's actually, no, it's more than one joint. So if you can see in this graph, demonstrate, it's color-coded. So each part of the craniocervical junction have certain degree contribution for flexion extension. For example, when you flexion extension, it's mainly occipital condyle, lesser degree to the C1. And for extension, for example, it's more C1 compared to the bag. So same thing for the rotation. So it's not, you cannot say, flexion extension, occipital condyle C1, and the lateral rotation, it's a C1, C2. It's all complementary for each one to other. And based on that graph, you can see the distribution of range of motion for each joint. And same thing, when you're looking at parameters, there's lots of number of parameters for the craniocervical junction, cranial index, cranial slope, cranial tilt. All these numbers reflected based on the sagittal alignment. It's it basically starts from the pelvic incidence. So if you look for this next slide, so we know there's clear correlation between pelvic incidence and sacral slope, which is reflected by pelvic tilt and L1S1 lordosis, and that results in correlation to thoracic kyphosis. So if you lose lumbar lordosis, it will affect the thoracic kyphosis. So as a consequence for that, if you lose thoracic kyphosis, it will reflect on the C7 slope and C2, C7 lordosis, and that will be reflected on C2 slope. So there's a chain of the correlation. And as you know, patient with a back problem, it can affect the craniocervical junction because it's a last compensatory mechanism to gain your sagittal alignment. So we'll come to some case elaborate this concept, dominant effect. So this first case, a 6-year-old girl with gait imbalance and dizziness, 2 days. Initially to present one of the hospital with acute drop level consciousness, and her image done showed this bilateral bica infarct. She is transferred to our center for further treatment, and you can see in her MRI this bilateral bica infarct. There's no history of trauma. She's medically free from where we can get. But when you do the further image, you can see the occipital condyle C1 joint is extremely wide, and occipital C1, C2 joint also extremely wide and hyperintense in T2. And also you can see on the CTA, you can see the vertebral artery is kinked between the C1 and C2 joint. Very unusual entity, but that's the etiology for the infarct. So she's on bilateral infarct. So this is the cause for the infarct on the right side. When you dig deep on the image, you can see there's arcuate foramen. I'm not sure if the mouse, you can see it, but there's arcuate foramen above the C1 lateral arch. This is another etiology for her bica infarct on the contralateral side. The other thing, you can see the vertebral body, it's really collapsed, and also there's also intolerance. There's lots of things going on for this patient. So bilateral bica infarct, one, the bica vertebral artery is kinked between the C1 and C2, and the other one, there's arcuate foramen, which is kinked the vertebral artery on the left side. Plus, there's also odontodium. You can see a vertebral body is extremely small. So this, you can see that you're dealing with the bony disease, and result, as you said, the craniocervical junction depends on the ligament. So if you have bony disease, it will affect the ligament attachment. That will cause secondary instability. So for this areas, we don't have really good support. So you lose the ligament. Even if you do fixation, you need extra support. So for this case, you can see, so we need to treat the cause of bica infarct. You can see it here in this video. Yes, sorry, I will go back. Yeah, in this video, so it's demonstration, you can see the C1 lateral mass screw, the C2 vertical screw, and this is the arcuate foramen, and you can see vertebral artery getting kinked. So I'm trying to mobilize the vertebral artery, and you would carry some 1 millimeter, decompressing the vertebral artery on the left side, And the other one to prevent further, and the other one to prevent, because the other side, the vertebral artery is kinked between the C1, C2 joint. It's every time she's moving her neck, the vertebral artery went inside C1, C2 joint and causing bike infarct. And that's what I did. You can see here to solve this problem. So I did bilateral cages between C1, C2, and that helped her to restore the alignment, because the key for this case, you need to restore the alignment. I know it's only short segment, but you need to achieve really good lordosis. You need to avoid too much lordosis, because the body tries to compensate with the kyphosis for the subaxial cervical spine. So you need it just perfect. So two things: decompose the vertebral artery bilaterally, one by inserting the cage, and the other side to remove the arcuate foramen, and also just perfect lordosis to maintain her alignment. So this is one case demonstrate the dominant effect for craniocervical junction fusion. The second one, this is 12-year-old boy sustained trauma after a fall from motorbike. After this minor trauma, I started complaining of severe neck pain with the tilt, getting worse over time, and transfer to me for further treatment after 6 months. So it's a late presentation for torticollis. So the CT scan, you see there's lots of things. So you can see the ADI, it's almost 12 millimeter. There is a significant neck tilt. You can see the C1, C2, this space of the joint is completely collapsed, and that's a cause of the tilt. You can see I call it pseudoscoliosis, because it's just a compensatory mechanism. The body try to compensate because there's a tilt, there's subluxation. So the only mechanism to open the canal doing a rotation, the subaxial cervical spine, and that's called pseudosubluxation, not really pseudoscoliosis, not actual scoliosis. And you see MRI, you can see the density is subluxed posteriorly, ADI is more than 12 millimeter, partial return of transverse ligament. So there's lots of factors going on for this patient. So to address this one, you need to have perfect alignment for the craniocervical junction. All this subaxial scoliosis, pseudoscoliosis, it should correct, because this is just as a compensatory mechanism. The body try to maintain and to open the spinal canal. So if you go for this one, so I need to open the joint between the C1 and C2, because it's congenitally it's collapsed. So you need to put something to open it and to balance the craniocervical junction on the coronal plane, and also to decrease the ADI. Normally it should be 3, but this patient 12. So that will have perfect coronal and sagittal profile. So with the osteotomy between the C1, C2, you open it, widen, and after that, putting cage, that will restore the alignment of the craniocervical junction. So this is his CT scan. So I put unilateral cage, so that will make sure the alignment just perfect between two joints, so it will be parallel. You can see in the CT scan, the lower cut, you see the coronal alignment of the craniocervical junction is well balanced, and also the scoliosis, which is really pseudoscoliosis, it's maintained with normal cervical lordosis after reduction and decreasing the ADI from 12 to 3 millimeter. So this is another dominant effect demonstration of the craniocervical junction for spinal alignment. Another case, this routine case, this boy with the progressive myelopathy secondary to Down syndrome. You can see the C1 is completely subluxed, and the other thing, there's osteodentoidium, and it came exactly between the C1 arch and the dens. So you see the dens, and also the osteodentoidium between the arch and the anterior arch. So for this one, the key to maintain, you can see the CT scan before the surgery, there's almost a straight cervical spine, but after the reduction, indirectly you maintain the subaxial cervical spine. So that will be consequences for on this whole spine's balance for this patient, because if you don't maintain the subaxial cervical spine, result in that would affect the thoracic kyphosis, lumbar lordosis. The patient will try to use all the compensatory mechanism from the hip and the knee. So fixing this region, the golden region, the craniocervical region, it will affect the whole spinal balance. The next case, this is 23 months girl with the myelopathy cavular spot. So it's typical NF1. You can see she's having cervical kyphosis, and it was over time, getting worse over time, resulting from that C1, C2 subluxation. So for this one, I'd say, you know, bone is not the best for this cases. She's NF1, she's only 23 months. So for this case, you need to reduce the C1, C2, and also the subaxial cervical spine. Resulting in that, you will prevent long-term consequences from losing the thoracic kyphosis and lumbar lordosis. This is another case, 14-year-old female with Marquis syndrome. She's having severe kyphosis. You know, she was following a different hospital. The kyphosis getting worse to the point she subluxed her C1, C2, and affecting her her balance. So for this one, all this one resulting in a domino effect. So because one thing, if the compensatory mechanism reaching the golden region with the craniocervical junction, you need to fuse that areas. So that's why early diagnosing, starting with the primary area of the problem, it will address the consequences of the craniocervical junction. This one, you know, some cases it's really tough. For example, this one, 32 with congenital deformity, it was neglected. He came to me when he's having severe myelopathy and also sleep apnea. So for this case, it's really tough. So you need to try to your best. You need to decompose the neural structure. Like the C1 lateral mass on the right side is basically it was intracranial. So you need to do craniotomy to put a screw at that area. And also you need to, and also vertebral artery course was not the normal, but you can see I'm trying to make his head as much as you can centered and also stop the deformity from getting worse and decompose the neural structure. The other thing, always I said, pediatric is different. So I did almost a 70 kid less than 5 years old of age. You can see when you fuse the craniocervical junction early on, the range of motion will not be affected. As I said, you know, the range of motion, flexion extension is not accepted under C1. It's a work multiple joint from the cranium down to the C1, C2. But if you fix this joint early on, the subaxial will take over. You can see this patient fixed from the occiput to C2, but you can see very nice flexion extension. You cannot tell if this patient really fixed from his craniocervical junction. So this is really important point to keep it in your mind when you fix a young kid with the craniocervical junction. This is a complex case, so just highlight one thing from this case because we need at least 1 hour to explain this case. So this is a 4-year-old female with a Klippel 5 present to me with the progressive quadribraces and severe dysphagia. You can see all the thoracic is having fusion and also her neck tilted backward with the fixed flexion deformity. She's only 4 years old, present with the severe dysphagia quadribraces, and this is her CT scan. So she underwent some decompression posteriorly, but you can see her spinal cord is severely kinked. She cannot open her mouth, her neck fixed deformity. For this one case, you need to think really outside the box. So you cannot go anterior, even if you go through the sternum, her mouth is a small, her neck fixed deformity, posterior, you know, already she's decomposed posteriorly. So for this one, you need to go, what I did for this case, I went laterally. And because you can see the dens is way intracranial, to reach the decomposed spinal cord, I need to remove the lateral mass one side, C1 anterior arch, and lower third of the clivus. Then you will be able to decompose and remove the dens, the basal invagination. Then after that, we'll be able to achieve realignment of her spine. And that will able even not only decompose the neural structure, she'll be able to walk like in the straight, good alignment for her spine, avoiding her knee and knee flexion and hip as a compensatory mechanism. And this is her CT scan before and after. You can see her with the 3D pictures, her neck before the surgery and after surgery, just perfect alignment for her neck. She looks straight. This is her first time she's able to see her neck, and her dysphagia improved, her breathing is improved. It's all about decompose the neural structure and always alignment. Alignment is the key success for these cases. And thank you very much.
Thank you so much. It was a very insightful presentation. And thank you so much for presenting this to us and presenting your extensive experience with pediatric cases, which are always not very easy to do. Thank you again, and thanks for sharing your time from your Saturday. Probably you're not working Saturday, and this is your personal time. Thank you again. The next speaker that we have is, and the last from today is a speaker from China, Dr. Duan Van Ru, that will present to us their experience at C1, C2. Please, Dr. Ru. Hello? Imat, do we have Dr. Wan Ru? Imat, can you hear us?
Yes. Can you hear me?
Yes. Okay. So can you, Dr. Wan Ru, can you share your screen, please, for us?
Yeah, sure. I will share my screens. Can you see my screen? Hi, can you see my screen, Professor?
Yes, we can see a screen, yes.
Great. Okay. So, dear colleagues, my name is Wan Duan. I am from China. I'm a neurosurgeon, and I will be represent instead of Professor Zhan Chen, our department chief, to share with you our 5 years experience with posterior facet destruction and fusion technique for atlantoaxial dislocation. We have nothing to disclose. And atlantoaxial dislocation can be broadly categorized into 2 types. Type A is atlantoaxial dislocation without basilar imagination, and type B is with basilar imagination. As to the pathological factors, in China, we usually mostly seen is the congenital factors, such as the occipitalized atlas and the Klippel syndrome. And sometimes we see cases with secondary factors like rheumatoid arthritis. So the aim of the surgery is to achieve the reduction and fusion and stability. Traditionally, the treatment of the lateral osseo dislocation has relied on methods such as skull traction and transoral anterior release. Until now, the skull traction is often used initially to attempt reduction. And Professor Wang Chao from China reported in the 2010 their technique after anterior release. They do the posterior fixation using the technique of first plate is tightened to the C2 pedicle screws and then compressed to the occipital bone. And Professor Jian reported this direct destruction between the occipital plate and the C2 screws to achieve reduction. However, there are several challenges associated with these traditional methods. The deformity of the facet and the tightness of the anterior ligament can make reduction extremely difficult. In fact, reduction failure is not uncommon. Here are cases of reduction failure, such as for this case, the surgeons did not achieve successfully this restoration. And in some cases, although the reduction achieved immediately after the surgery, but will last a few weeks or months after the surgery. And sometimes we can see the breakage of the screws, which is also the implant failure. So in this case, surgeons have to do some like transoral anterior release to do the revision surgery. After the Professor Gao reported the atlantoaxial joint distraction technique in 2004, we developed our technique, that is the posterior facet distraction and fusion. Using this technique, after we do the C1 and C2 distraction using some special designed surgical tools, we insert a cage with different size to achieve the reduction. So we will pull the odontoid downward and lean anteriorly to achieve the reduction of the dislocation. Here is the image of our technique. We insert different size cages and do the cantilever technique to achieve the horizontal dislocation. Using this technique, we can achieve very successful reduction for most cases. Here is a specially designed surgical tools, and then we use these tools to achieve the reduction. Here is an all-arm image during the surgery. So we use the trial cages to see if we can achieve the complete reduction. Here is a video we published in the operative neurosurgery.
Syrinx of the upper cervical spine. Three-dimensional CT reconstruction shows an odontoid above Chamberlain's line is 12 millimeters, and the atlantodental interval is 5 gram. Showed a normal course of the vertebral, placed prone onto the operating room table with cervical traction of 1/8 of the body weight, in this case 7.5 kilograms. Care was taken not to injure the vertebral arteries. The atlantoaxial facet joints were already slightly distracted from the cervical traction. A microsurgical dissector was then used to explore the intra-articular joints and 4 millimeters, and a 4 millimeter trial was inserted into the space. A 4 millimeter intra-articular distractor was then inserted into the right facet joint and gently rotated until the intra-articular space was enlarged to 4 millimeters. The distractors were specifically designed with blunt edges and enlarging sizes. A 4 millimeter trial was also placed into the right facet joint. After this had been done, the left side 4 millimeter trial was 5 millimeter intra-articular distractor was then used in the left joint and gently rotated until the intra-articular opening millimeters. An O-arm image showed that the basilar vagination had been completely reduced and the atlantodental interval was significantly reduced. A height of 9 millimeters filled with autologous iliac crest bone graft were implanted into the bilateral intra-articular spaces. The angle of insertion of the spacers should be in line with the surface of the intra-articular joints in order to avoid undue force on the bony surfaces of the facets and possible fracture of the cortices. C2 PARS screws of 24 millimeters were placed bilaterally. An occipital plate with reduction set screws was attached to the occiput using midline screws. Contoured rods were first placed into the C2 screw heads, and the C2 set screws were tightened, locking the distal end of the rods into C2. Then the rods were reduced by cantilever into the occipital reduction screws, angling the C2 body forward and pushing the dens ventrally. Reduction of the atlantodental interval and basilar vagination was confirmed, and the set screws were tightened. A postoperative CT scan showed complete reduction of the atlantoaxial dislocation and of the basilar invagination. The clival canal angle and cervical alignment were also improved. And MRI showed good decompression of the brainstem. Syrinx of the upper cervical spine. Three-dimensional.
So our technique is suitable for the reducible atlantoaxial dislocation cases, and also for the irreducible atlantoaxial dislocation cases, we can also achieve a complete reduction, especially for these cases with the bony fusion between the C1 and C2 joint. We can still do the distraction between the C1 and C2 joints. And here is a type B atlantoaxial dislocation. So we put in a large cage to achieve a complete reduction. And also for the rheumatoid the cases, and also for some rotation cases, after we insert different sides of the cage, we can reduce the rotation. And we can still do the revision surgery even for the cases with defect occipital bones. In that case, we put the screw into the occipital condyle. As our technique is aligned with the Wolff's law, which is the golden standard for the spinal fusion, we usually achieve a reliable bone fusion at very early after the surgery. Here are the manuscripts we published in the recent 5 years. Here is we reported how we did the posterior revision surgery using our technique, and for young child, we also achieve nice results. And for those with bony fusion cases, we can distract the C1 and C2 joint during the surgery and achieve reduction using the one-stage posterior surgery. And also we studied the biomechanic investigation. So why using our technique, we can achieve a good fixation. And also we can achieve the good reduction of the spinal cord and protect the malformed vertebral artery using some special designed tools, so that during the destruction of the C1 and C2, we will not injure the vertebral artery. And also we study the quantitative correction of the cervical sagittal deformity in the atlantoaxial dislocation. We published 3 papers in this study. So we designed different size and different angle cages to achieve quantitative reduction. Here is a manuscript we published in the 2019 and reported 135 patients with using our technique. The reduction successful rate is 95%, and the fusion rate is 92%, and the complication rate is less than 5%. So for take-home message, the PFDF technique is a simple and effective technique for atlantoaxial dislocation. It will replace the need of anterior surgery in most cases and enhance the stability of the reduction and increase the bone fusion rate. So thank you. Here's the end of the report.
Thank you so much, Dr. Wanru. It was a very good and insightful presentation, and thank you so much for sharing your extensive experience of many cases done with your technique. Definitely something that was, I believe, beneficial for our participants in the webinar today. So if there is any questions for the presenters, please write in the chat. I don't see any chat questions at the minute, but because we are running slightly late today because of the presentations were slightly longer than we planned, I suggest that if you have any questions for the presenters, please write in the chat, and we will be happy to make connections and to answer these questions. So I'm going to close the webinar today. Thank you so much for all the participants, and thank you so much to the lecturers that are sharing their valuable time with us and
Nikolai,
sharing their valuable experience.
Nikolai, before you close,
Yes.
is Atul Goel still there, or has he gone away? We cannot close this webinar on CV Junction without comments from Professor Goel.
I agree with you. So if Atul is there, I'll be happy to listen what he says.
Atul, unmute yourself. Yeah.
Yeah. So thank you very much, my dear friends. Craniovertebral junction is indeed a complex issue. Craniovertebral junction surgery is not easy, as we know. And craniovertebral junction, most important thing is we should remember that any complication in craniovertebral junction surgery can be absolutely devastating. Means the patient will neither live and neither die. And he will just keep on troubling you till the time, you are done with. So we have to be absolutely good and absolutely clear and absolutely philosophical in our understanding and in our treatment. And what treatment we have seen, Dr. Sushil Patkar has shown repeatedly about the efficacy of anterior surgery. There are various groups who agree with this, and there are many groups who are doing this anterior surgery in the world. And many people are doing posterior surgery. What is important is, in craniovertebral junction surgery, my feeling is instability is the issue. Instability. And stabilization is the treatment. Fusion and ultimate bony arthrodesis is the ultimate aim of the surgery. Now, we had talked about realignment of the craniovertebral junction, the odontoid process coming down and realignment. Of course, realignment is necessary, and realignment is the best thing that should happen. But more than realignment, solid fixation, solid bone fusion, that is the key. And I think whoever has to do craniovertebral junction surgery has to be very, he has to understand the facets, he has to understand the vertebral artery, he has to be absolutely good in controlling the venous bleeding, absolutely, he has to understand the mechanics of screw, understand the mechanics of rods and plates, and then do the fusion. I think I enjoyed the presentations and enjoyed very solid presentation, of course, from my dear friend Patkar, who is, who has, when he talks, he is very emphatic, he says what he wants to say, and he proves his point. And of course, my friend Zan Chen and his group is doing good work on craniovertebral junction surgery. And the indications of craniovertebral junction stabilization, in my view, are increasing, like stabilization for Chiari, stabilization for sitting, stabilization for platybasia, stabilization for torticollis, stabilization for short neck, stabilization for clipple fight. The indications are increasing quite rapidly. And eventually what we have to do is we have to learn the art of C1, C2 fixation. C1, C2 fixation is the key. The other thing is inclusion of the occipital bone, which Dr. Wang from China, from Zan Chen's group, is saying. Occipital inclusion is, I have I described actually occipital screws in 1987. I did first occipital screw, but now over the years, my inclusion of my occipital bone in the fixation construct is not so frequent. Very rarely when there is extreme anatomical difficulty to do direct C1, C2. So that is another point that we must consider, that C1, C2 instability is the issue. C1, C2 stabilization is the treatment. Solid fusion and arthrodesis is the ultimate goal of treatment. Difficult operation, complications can happen, but if you do it properly, you can give a new life to the people. Absolute new life. And those who are doing craniovertebral junction surgery, you can imagine the joy when you go and see the patient and he says, "Doctor, my hands are moving, my legs are moving, I'm breathing properly." You have given a new life. So thank you for all the lectures, and my best wishes to all of you.
Thank you so much, Atul. It was a great closure of the session today.
Thank you. Thank you.
We were lucky to have you.
Thank you so much, Nikolai.
Okay, so all the best to everybody. Enjoy the rest of your Saturday, and I hope to see you again soon for new discussions and new insightful presentations. Bye-bye.
Bye-bye.